Oh, thank you very much. Thank you very much for having me. I'm appreciate the very kind the explain of me. I'm going to present the more localized hospital-based big data making and using for the precision medicine. So this is the era of the post-industrial revolution. Yes, what do you think the biggest difference between previous first and second, third industrial revolution and with the post-industrial revolution? Of course, there are many big differences, but the most important difference is the previous third industrial revolution is mainly the production revolution using steam engine and electronics and IT. It increased the production, mass production. But at the post-industrial revolution, we can the fusion and convergence with IoT, cloud, big data, AI, 5G, even 6G. Combine all of these, finally we can give some custom specific service. Like autonomous driving is a very good example. In the future medicine, we can give more patient-specific, the patient-specialized service. That is the precision medicine. So to provide that kind of the patient-specific service, we need more high-quality big data. But this is very big, difficult or problem. So right now, I'm the medical doctor and clinician, so I'm more focused on the electric or health record and medical record. As right now, each hospital is the below. Each hospital using their hospital information system and with a little bit different medical terms. So it is very difficult to making high quality big data. Right now, the best way to studying the big data is the OMO and CDM, something like that. But that is not perfect. But if we put the best quality of the EMR system on the cloud and share the kind of the EMR system, maybe we can collect high quality big data like as the one hospital. That is our idea and Korea government idea. We started 6 years ago, supported by Korea government. So we developed the kind of the cloud version of the hospital information system with Samsung SDS and Samsung Medical Center and Korea University Medical Center, and also the Naver Cloud. Naver is the kind of the Korean and Asian version of the Google as the number one portal in Korea. They provide the cloud. So we developed all kind of the IT system on the hospital. So the doctors and nurses, even the hospital management officers, 100% of the IT system we put on the cloud. The Korea University Hospital is a tertiary hospital. It treats the cancer and rare disease until the end of the disease process. It's a big hospital. This is the enterprise level, the cloud hospital information system. It is almost world first. Of course, there is the cloud hospital information system. It's about 200, 300 beds. Middle-sized hospitals they use. But this kind of the enterprise level the cloud hospital system is almost world first. So we developed all kind of the hospital environment as a module. So the base module is 24, and the selection module is 14. So each hospital, they choose the modules and they pay they use the modules. And also the unification of the clinical languages. In Korea, even the different hospitals are using a little bit different languages for kind of the stomach cancer. Some is the malignancy on the stomach, some is the gastric cancer or something like that. So we unification of the clinical language, and also to developing high quality big data, the more structured hospital information system. It was just typing it, but is more structured, and it is suitable to developing high quality big data. And also for life-log data, we developed the smartphone applications, we call it the personal health record, or we collecting patient life-log data. Actually, using that smartphone for if any kind of the medical device, if follow the international standard of Bluetooth, easily interface with that smartphone Pro. We already attached more than 150 various electrical device, medical device, even the smart watches and electrical blood pressure checkers, something like that. And also using this PHR, the patient know there are all kind of their healthcare data, except the doctor's prescription, doctor's prescription documents. So our goal is making really good big data and using this one to prevention the patient disease and management, more better diagnosis and better treatment. So last March, we finally opened the cloud system, and there are a few errors, but it is very common on the beta test area. But finally, it works very well. It fast more than 1 year and a half. It is works perfectly. Previously, many the IT personnel or doctors worry about the speed or something like that. But the speed is there isn't any difference between SI system and compared with this cloud system. So the effectiveness improved, and also the cost is reduced. Right now, the Korea University has 3 different Korea University affiliated hospitals. They are all tertiary hospitals. We share this cloud hospital information system. It can reduce the maintenance fee and settle down fee is up to 40% or 60%. So right now, only 3 Korea University affiliated hospitals using this system, but our plan is keep joining, including more hospitals and distribute more, recruiting more hospitals. So end of this year, 2 more general hospitals will join with us, and maybe end of next year, it will be up to 8. should be, I hope, could be the basic, the standard, the hospital information system in Korea. We're going to make our vision is to developing high quality big data in Korea. And then we're going to expand to internationally. So if each hospital is joining this kind of the cloud hospital information system, we can make the really high quality big data easily. So the hospital is different, but we using the same hospital system and the standardized medical terminology, so we can collect data like as one hospital. And we can make a high quality big data dam, and we can develop the more patient-specific AI solutions for prevention and diagnosis and treatment. We collaborate with various companies. We already developed these AIs, and we keep upgrade. The first one is the antibiotics advised AI. We developed it with this one is SK. SK is the fourth biggest company group, follow the Samsung, Hyundai, and LG. Though, you know, in 30 years, about 2050, WHO said the superbacteria is the biggest threat to human beings. The cancer is getting changed to more controllable the chronic disease, but overusing the antibiotics, superbacteria is getting more popular. It is could be the serious threat to human beings. So to prevent that kind of the disaster, we need more precise prescription and antibiotics. So we developed that kind of AIs. But this AI, at the time, we are developing this cloud-based hospital information system. So we used the 10 years Korea University electoral record retrospectively. But right now, as end of this year, the 5 big hospitals joining this cloud-based hospital information system. So to develop that kind of the AI system, we can prospectively collect data 2 years. And then prospective collect data is a much better the quality. It can improve the outcome of the AI. If joining the hospital increases up to 10, it takes 1 year. Better the quality of big data is going to improve the AIs. And also we developed the bone age detecting AI. This is the very first AI program approved by Korea FDA. Before approval, our radiologist doctors, they refused reading the bone age without this AI. Before using this AI, it takes at least 5 minutes reading each patient. By using this one, it takes less than 30 minutes. Within 1 or 2 seconds, AI suggests, and then the professor or resident a little bit change. It takes 30 seconds or 1 minute. And also the other thing is the AI for planning of the dental, the implant. You know, precisely planning for the dental implant, it takes about 20 minutes. But on the outpatient clinic, it takes 20 minutes. It is a limit the outpatient the treatment. But using this AI, it markedly reduced and up to 5 minutes. So that kind of things we develop and using. And also, this is the imaging AIs to evaluate over the breast cancer, brain hemorrhage, and brain aneurysm, and lung cancers, the various imaging AIs we already use. And also, we're using the detection of the sepsis to early detection is and is it very important to save the patient from the sepsis. But the sepsis, to detect sepsis, we carefully monitoring their vital signs and some oxygen, the saturation level on the artery, something like that. But the nurses, they're very busy. It is almost impossible to very carefully observe the one patient. But AI is that is the very easiest job. Yes, they repeat and very fast. So after using this one, we improved about 30% of the detection. And also the AI, we using the rapid response system. After patient come back to the normal ward from the ICU, but the patient sometimes got the cardiac arrest. So this is the good system. And also, after the developing cloud hospital emergency system, we applied the HIMSS, the digital health indicator. At the time, the interoperability is we ranked the #1, and predictive analytics scored the #2, and we got award. This is the data governance scores in the countries, and this is the OECD the countries availability internationally, the availability of the data. Finland, Australia, and they are good, but South Korea, Japan, and United States, they're almost no. This is my final slide. I'm the clinician. I'm more focused on the local hospital-based the big data. This is one of the good method to developing and using the medical big data to treat the better, making better outcome, prevention, and diagnosis and treatment. Yeah, thank you. Thank you very much.
Thank you. Thank you, Dr. Lee. Thank you so much for this amazing journey from technology to patients. And I think we have 3 minutes for questions. So if you're speedily in your question, we get a speedily answer, you get at least 3 questions. Precise questions. One there, and another one here. And that's it, adjudicated.
Adjudication done. So I'm thinking of the first one. Thanks a lot for the session. It was really, really interesting. So when you talk about assembling data from different sources, having the same data model is really the key aspect to me. Otherwise, you can't do any federated analytics, nothing. So the question is like, how much effort is that to actually do it? And what I mean is like warm bodies and people doing curation and putting different heterogeneous data into a common model. And then the second question is more to Ségolène is whether you do have other data modality than the clinical, something like imaging from H&E slides or everything like that. Okay, thanks. I got to know for the second. But for the first one, how much effort is to put heterogeneous data set under a common data model? Thanks.
Actually, CDM common data model is that is a very good way, but I'm more of course our system has the CDM model, but I'm more focus on the cloud system. Cloud system is, we don't need mapping like the CDM. So just one system is a joining, like you using the Netflix. So you don't need mapping French and American and Korean. So this is the technically is challengeable, but if you make in one good cloud system, we can markedly saving that kind of the mapping cost. So that is the great advantage of this.
Thank you. Segalen?
About what?
I think the question was, the second part of the question was for you
yeah.
on the,
So, no,
on the types of data besides clinical.
currently in the main database, the administrative one, there is nothing more than the discharge summaries from the hospital, so we don't have any imaging. But, you know, in the project to link with the repositories established by the hospitals, you know, of course, this is the hope that we will, at the end, access imaging data, because it's key for what we want to achieve. But for that, you know, the repositories have to exist. So currently there is a call for proposals from the French government to support the development of these repositories by hospitals. So I hope this will be successful and that in the future we will. And we don't have also any data on omics, which of course is necessary for most research projects.
Thank you very much. Over to you.
Tony Andreu from Beatrice. Thank you to the three speakers for these exciting presentations. I have a question for Segalen. What's the strategy of the hub for reassuring compliance with the FAIR principles of the data providers? Is something that you do from the hub, or is something that you do together with the data providers? Thank you.
So, of course, I think the whole project is fair by definition, because it's providing access, you know, without any restriction to those having a good reason to access this data. So there is just a verification that the project is of interest and that it respects the let's say regulatory obligations, and that it is ethical and scientifically sound. That's the only obstacle, you know. So I think that we are fair. So I don't understand why you worry that we do not.
Not about the project, of course, about the hub, but about the data providers and the culture of data provision in the data providers.
Yeah.
Thank you.
So the data providers, I think this is the biggest issue, and we have not yet discussed that at all. I mean, I think that it's good to have such an ambitious and national project as the HDH, but you know, in France we do not fund properly the data producers. So the communities which are dedicated to having big databases for research purpose, they hardly find a way to get funding. Usually they get funding to start the data collection because it's a new project, and after 3 or 5 years, you know, they can't have another funding because it's not new anymore. So if we do not solve that, I think there is no future for what we want to achieve. So it's a balance between having a decentralized project, but also develop a real process to ensure that the data providers have the capacity to do their job and to produce good data. For instance, a project like the one in Korea, yeah, you see the effort to organize the hospitals to produce data which are usable after for research purpose, and you should not destroy the healthcare system and ask too much the practitioners to spend time, you know, in coding or typing things. So it's really very difficult, and especially the funding issue is a big one. In France, we have opponents, honestly, and these opponents are the scientists who dedicated their life in building up large cohorts and registries, because they know how hard it is for them to produce that, and they fear that the budget which is allocated to the national project is not available for them, and they will not get any support in the future. So I think we don't have reached the right balance yet, but we have set up a working group with the government to solve that issue, because for me it's crucial.
Thank you. And the final question from Canada to
Great.
our panel.
Thank you so much. Really exciting to hear about all these initiatives, and I bow to you in this, all the work that must have gone into this. My question is about the quality of the data. So, for instance, in the systems that were described, there's an enormous number of variables that would be collected. And I know for us, sometimes we get very excited when we look at the name of the variable, but when we actually get the data, there's a lot of observations missing. So you can't really do anything with it. And my best biostatistical colleagues don't have any suggestions either, because there's too much missingness. And then when you link, that problem is compounded. And I wonder to what extent this is the case in these very large cloud-linked databases.
It is the case.
How bad is it?
But you know, I think that it's why it's so important to have a dedicated team who has already experienced the limits of what is available, to guide the new researchers coming in with a new project, because we know the limits of what can be done, and we know the tables, and we know which ones are really usable and which ones are hopeless. But you are totally right. But you know, it's better to have the remaining good data than it's better than nothing. And so I think that at the end, the balance is very positive. So by accessing this very large database, which is about the data on 65 million people in France, you know, you can hope that you have enough data to do something.
Yeah.
Totally.
Actually, I totally agree with your opinion. That is a big problem. So, in my experience, to developing the antibiotic choosing AI, there are lots of data that missing. So, we need the data cleaning, and some the specialists, they sometimes the gas and peeling that, but that is the time consuming, and still data quality is not good. So that kind of the retrospective data is quality is not that great. So just reviewing the common or less quality of AIs can be developed using that data. But if we want really the good AI or the high quality the big data, that is a great advantage of this cloud system. We cannot make to developing the high quality big data, we cannot consuming the 10 years. But with the cloud system, so we can make it just 1 year. Actually, the cleaning and that kind of the things, we spend more than 1.5 years. But the prospective collecting data, we collecting data, and then end of the year, 1 year, we can finish the high quality big data, and then the best AI we can have it.
Thank you very much for the profound answers, the good questions, the time you gave our panel, and thank you very much.